Good morning. Today we'll be discussing on drug-drug interaction. Under this drug-drug interaction, we'll be looking at the following. 1. Introduction to drug-drug interaction. We classify drug-drug interaction and we give conclusion. The most important thing in drug-drug interaction is knowing the classification and the examples within them. So let's start with the introduction. Now, what is drug-drug interaction? When you co-administer two drugs together, two or more drugs are being given together. One drug can affect the effect of another. Sometimes both of them can actually affect the effects, such that it can alter how the drug is supposed to act. It can make it more toxic, or it can make it more effective. All of these are drug-drug interaction. So drug-drug interaction occurs when drugs are co-administered. It can result in alteration of the pharmacokinetics or the pharmacodynamics of a drug. It can result in severe condition. It can also reduce the therapeutic effect of a drug when you co-administer two drugs together. It's mainly seen in the elderly, where you experience polypharmacy, where they take a lot of drugs. They have a lot of drugs they take for rheumatism, for this, and there can be actually drug-drug interaction a lot. That does not mean it's not seen. It's seen in all walks of life, but we're just saying it's very common in the elderly. All right. Next, classification of drug-drug interaction. To classify drug-drug interaction, we can classify it into two: pharmacokinetic drug-drug interaction and pharmacodynamic drug-drug interaction. When you say pharmacokinetic drug-drug interaction, simply you are saying these drug-drug interaction affect the pharmacokinetic. When two drugs are being administered, the pharmacokinetic of this drug are being affected. What's pharmacokinetic? Remember, it involves absorption, distribution, metabolism, and excretion. If administration of one drug affects the metabolism of another, that's pharmacokinetic drug-drug interaction. If administration of a drug affects the absorption of another, that's pharmacokinetic drug-drug interaction. Do you get now? So this is what we'll be discussing on. How those the absorption of the absorption of some drugs affected when it is being administered with another. Do you get now? So let's quickly go to the next slide here. This is what we just explained. Pharmacokinetic involve this: absorption, distribution, metabolism, and excretion. Any of them being affected is pharmacokinetic drug-drug interaction. So we want to talk about that of absorption. For absorption, now there's a drug called tetracycline. Tetracycline is an antibiotic, which we all know. When tetracycline is being administered with magnesium and aluminum trisilicate, which are used in the treatment of peptic ulcer disease, if you should give magnesium or aluminum trisilicate to an individual and tetracycline at the same time, the absorption of tetracycline is being reduced. Tetracycline is not absorbed the way it's supposed to. Why? Because this aluminium and magnesium trisilicate, they actually have what we refer to as chelating agents. They have chelating agents. You see, aluminum trisilicate, it has aluminium. Aluminium is a chelating agent. It makes tetracycline to come together and prevent its absorption. It does not allow it to be absorbed. It just chelates it. It holds it, prevents it from getting absorbed. That's an example of what? Of absorption. Drug-drug interaction during absorption. Do you get now? So tetracycline will form an insoluble complex with this ion, and that will reduce its absorption in the GIT. So that's an example of an absorption drug-drug reaction. All right. So after that, we want to look at another example. And another example of an absorption drug-drug interaction is where we have cholestyramine and cholestyramine. These ones are from bile acid, cholestyramine and cholestyramine. Cholestyramine actually is a drug. You see cholestyramine later. It's a drug that is used in obstetric and gynecology in the treatment of somebody that have intrahepatic cholestasis, like intrahepatic cholestasis, where the amount of bile is bile acid is increased, causing itching. You can use this drug to treat them. So it's a drug. So cholestyramine and cholestyramine, they actually prevent the absorption of some drugs like warfarin, just like digoxin. When they are administered together, they prevent the what now? The absorption. So cholestyramine and cholestyramine and cholestyramine, they can actually prevent or reduce the absorption of warfarin and digoxin by binding to them, reducing their absorption. So when they are co-administered, the absorption of warfarin and digoxin is altered. That's drug-drug interaction. Absorption drug-drug interaction. That's pharmacokinetic drug-drug interaction. Let's go to distribution. Now, it is important to know for distribution that for a drug to be distributed, it binds to plasma proteins. Plasma proteins, specifically albumin, is responsible for the transport of drugs. Now, this is the catch. There are some drugs that have more affinity to bind to what? To albumin. When you co-administer that drug that have high affinity to actually bind to albumin, you give that drug with another drug that don't have that much high affinity. That one that has high affinity will bind to the albumin that is supposed to transport the other drug, and the other drug will just remain there in the body. It will not have any way of being transported. It's affecting the distribution of that drug. Do you get now? That's what we refer to as distribution drug-drug interaction. It's an example of pharmacokinetic drug-drug interaction. Let's go. A drug may displace another drug from its plasma protein sites. Do you get that now? This causes an increase in the plasma concentration of the unbounded drug. Let me say, for example, you administer drug A and B. Before we look at the major example here, administer drug A and B. Drug A can bind to plasma protein very well, whereas drug B can't do that very well. So drug A will bind to the plasma protein, drug B will have nowhere to bind to, so it will be found freely in the system. It is important to know that free drugs are active drugs. A drug that is bounded to plasma protein is not active. When a drug binds to plasma protein, it's just for transportation of that drug. It is not active. Drugs that are bounded are not active drugs. The free drugs are active. So now a drug that doesn't have that capacity to bind to plasma protein the whole lot, you administer it to the drug that have that high capacity to bend. It will bend. The one that have the high capacity, drug A, will bend to all the plasma protein. Drug B will have nothing to bend to, and drug B will be free drug in the system. Its toxicity will be increased compared to the way it's supposed to be. Do you get now? And this potential, that's what this. Let's get that statement again. A drug may displace another drug from its plasma protein binding site, and this increase the plasma concentration of the unbounded drug. It has nowhere to bind to, so it increases its concentration and it potentiates the drug toxicity. Do you get now? Or sometimes it can increase its efficacy. Sometimes it has positive effect, sometimes it has negative effect, but it will be in the amount of that drug in the system, in the plasma concentration will be, the plasma concentration of that drug will be increased. Do you get now? Let's look at example. Phenylbutazone is a drug. Sulfonamide is another drug. These two drugs have high ability to bind to plasma protein. So if you co-administer them with other drugs like warfarin, what will happen? They will displace warfarin, and therefore warfarin toxicity will occur. They will bind to warfarin binding site. That's supposed to be where warfarin is supposed to bind to plasma protein. They will bind to those sites. Warfarin will be found freely in the system. So note two drugs that have high ability to bind to plasma protein we've already mentioned: phenylbutazone and sulfonamide. This results in the increase of the free unbounded warfarin, and this increases warfarin toxicity. All right, move to the next slide. Sulfonamide can also displace bilirubin. Yes, plasma protein albumin is what also helps to transport bilirubin to the liver to make an unconjugated bilirubin becomes conjugated so that it can leave the body. However, sulfonamide can displace bilirubin, and that can actually result in hyperbilirubinemia, excessive unconjugated bilirubin in the system. Do you get now? That's another example. One last example. Quinidine also has high ability to bind to plasma protein. It can displace digoxin. And once it displaces digoxin, there will be increase in the use of digoxin toxicity because it will be free in the system. Hope you understand this explanation. So that's just it. So just remember the drugs that has this high binding ability. Phenylbutazone, remember it. Sulfonamide, remember it. Quinidine, they have high ability. When they administer them with things like warfarin, you are just increasing the toxicity of those drugs. Let's now go to metabolism. Number 3, metabolism. For metabolism, remember, metabolism simply means the process whereby a drug that is that is lipid soluble is being converted to its water soluble form so that it can easily be excreted, and that is actually by the help of the liver. Now, we said the liver has different sites that helps to bring about metabolism, but the most important site is the microsome. And the reason why the microsome is most important, one of the reasons, is because it contains cytochrome P450 enzymes. And these cytochrome P450 enzymes are necessary for bringing about breaking down of drugs, converting them from lipid soluble form to their water soluble form so that they can be excreted by the kidneys. Now, there's something you should know. We said if there are some drugs which we call inhibitors, some drugs which we call inducers. Inducers are drugs that can act on enzyme like cytochrome P450. No, cytochrome P450 is what helps to bring metabolism in most drugs. Good. Now, there are some inducers, they will act on that cytochrome P450 to make it work better, to make it work faster. Inhibitors are drugs that can act on cytochrome P450 or that enzyme to make it not to work fast or to reduce or to prevent its action. Do you get now? Now, this is the catch. If you should give an individual two drugs, one of the drug is an inducer. It will make cytochrome P450 to work faster. And once it makes cytochrome P450 to work faster, it will break the second drug faster. Do you get now? It will break the second drug faster than it's supposed to. If you co-administer two drugs, one of them is an inhibitor, it will make cytochrome P450 to act slower. And you will not be able to break that down drug the way it's supposed to. And the drug will remain in the system for a longer time. And that can cause toxicity. Do you get now? Now, let me give you an example. Imagine a woman who takes an oral contraceptive. Yes, oral contraceptives. That's, for example, she takes a drug to prevent pregnancy. That's oral contraceptive means to prevent pregnancy. Good. A different example of oral contraceptive. And now she take an inducer. Oral contraceptive is supposed to prevent pregnancy for some time. And now you take an inducer. Inducer make that cytochrome P450. A drug that's an inducer will make cytochrome P450 to work faster. It will break down when you co-administer contraceptives and this cytochrome P450 inducer drug. It will make cytochrome P450 to work faster. So that it will break the contraceptive faster. A drug that's supposed to prevent pregnancy for 72 hours will now be preventing pregnancy for a lesser time because it has broken down the contraceptive very fast. Cytochrome P450 is working faster. Do you get the catch now? So let's quickly go to this. Metabolism. Drug interacts by inhibiting the metabolism of other drugs. Now, it is important to know for metabolism that the important enzyme involved in metabolism is cytochrome P450 family. Do you get now? Cytochrome P450 family. Good. Next, some drugs they are inducers. They can induce cytochrome P450 to work better. Some of them are inhibitors. They can reduce the effect of cytochrome P450. Now, example of inducers is what we want to mention now. You should know them. It's an MCQ. Phenobarbital is an inducer. I remember phenobarbital. We mentioned it as an example of barbiturates in anti-seizure drugs. Okay. Rifampicin, griseofulvin, remember it is an example of antifungi. Phenytoin, we mentioned phenytoin. We already mentioned phenytoin already. Hydratoin. Ethanol, carbamazepine, we mentioned carbamazepine already. Is that not true? Yes. Immunostimine example for anti-seizure drugs. Most of the drugs have mentioned some anti-seizures. 3 anti-seizure drugs mentioned here. They are all example of inducers. Do you get now? They actually cause cytochrome P450 to work better and break down drugs faster. So when you administer these drugs with other drugs, breaks those drugs faster. Do you get now? All right. Hence, the metabolism of drugs like warfarin, oral contraceptive, and corticosteroid is actually increased. It enhanced the metabolism. So if somebody should take oral contraceptive and take carbamazepine, the girl, for example, a woman normally comes up with seizure, and then she's taking carbamazepine, and then she takes oral contraceptives. The oral contraceptive works, just break down quickly, because what now? This carbamazepine is an inducer. It causes cytochrome P450 to work faster in breaking down that drug. Inhibitors. Example of inhibitors. These ones, remember, they prevent the action of cytochrome P450 from actually going on fast. They include ketoconazole, antifungal, erythromycin, antibiotics, ciprofloxacin, antibiotic, Then fluoxamine, this is an example of an antidepressant. We talk about that. Before you talk about antidepressant, please you can watch the video on that. Indapamide, Botanavir, these are retroviral drugs. They are drugs for treating retroviral diseases. All right, now they are inhibitors. So what is the consequences when you administer these drugs you mentioned with another drug? It can reduce the amount of time. It can increase the amount of time needed to break them down, because the enzyme they're supposed to break them, to put an hot to them, it will inhibit that enzyme. So those drugs will remain in the body for a longer time, and that can cause toxicity. So consequently, these drugs can actually result in elevating other drugs level, because they will not be broken down. That can increase efficacy or toxicity. You are getting the point, right? So let's quickly go to examples here. I want to give few examples, I think. Okay, they said some drugs known as prodrugs. We know prodrugs are drugs that actually do what now? That actually, let me explain before we talk about this. Prodrugs are drugs that are actually inactive, but after they undergo metabolism, they become active. Unlike most drugs that they are active, after metabolism, they become inactive. So for a prodrug to become active, must undergo metabolism. Do you get that point now? Now, imagine that you are giving somebody a prodrug and you are giving the person an inhibitor. What happened? That prodrug, will it be converted to its active form? No, because that enzyme is supposed to metabolize the drug to become active. Now, if that enzyme is being inhibited, it will not become active. Do you get now? It cannot act on the other drug to make it active. Let's give an example. This example will make everything sound so interesting. Now, there's what we refer to as paroxetine. Paroxetine is actually a drug that is used to treat depression. It's an antidepressant. Yes, this paroxetine is an inhibitor. Do you get now? It is an inhibitor. When we say it's an inhibitor, this means it actually reduces the action of cytochrome P450. Now, when you administer paroxetine and tamoxifen is an example of a drug that you use to treat what now? Breast cancer. Tamoxifen is a prodrug. It needs to be converted from tamoxifen to its active form, which is endoxifen. So if you should give an inhibitor and tamoxifen, that inhibitor will prevent cytochrome P450 from acting on tamoxifen. It's cytochrome P450 that is supposed to convert tamoxifen to endoxifen, its active form. And when that is inhibited, tamoxifen will not be converted to endoxifen. And once tamoxifen is not converted to endoxifen, there is therapeutic failure. The woman that has had breast cancer is not solving her problem. So just look at the sequence. Simply put, an inhibitor is paroxetine. It inhibits cytochrome P450 2-decis. This is the enzyme it inhibits. It is this enzyme they're supposed to convert. So if you give somebody tamoxifen, this enzyme cytochrome P450 2-decis, they're supposed to convert that tamoxifen to endoxifen, its active form, because the prodrug is tamoxifen and its active form is endoxifen. But when you give paroxetine with tamoxifen, this paroxetine will prevent cytochrome P450 2-decis from performing its action, and as such, tamoxifen will remain like that in the body. It's not be converted to endoxifen. Do you get now? And that can increase the mortality rate of a woman with breast cancer, because her drug is not being converted to the active form. It remains in its inactive form. All right, so let's go to excretion. For excretion, simply put, one drug can prevent the excretion of another. Let's just look at some example. Probenecid can inhibit the excretion of drugs like penicillin and methotrexate. Do you get? Probenecid can inhibit the excretion of drugs like penicillin and methotrexate. All right. Furosemide can also decrease the excretion of indomethacin. You know furosemide, the diuretic. We'll talk about diuretics soon. Then indomethacin, you know about indomethacin. We'll talk about it in NSAIDs. So that's pharmacokinetic drug-drug interaction. You should know examples for absorption, tetracycline and those magnesium trisilicates. For distribution, you should know examples. Sulfonamide, having high binding activity for plasma proteins. It can displace warfarin. Sulfonamide can displace bilirubin, causing hyperbilirubinemia. Know those. Metabolism. That's where we talk about those inducers and inhibitors. Know the example of inducer and inhibitors. No tamoxifen. Endoxifen is the active form. If you give paroxetine with it, you are doing no good to the individual. Excretion. One drug prevents the excretion of another. Furosemide, decreasing the excretion of indomethacin. Let's now move on to pharmacodynamic drug-drug interaction. This one is very short. We'll be very fast with it. Pharmacodynamic drug-drug interaction. Simply put, pharmacodynamics actually deals with agonists, antagonists, dealing with receptors. Do you get now? If you should give somebody a drug, will this drug make the other drug you are giving to actually work faster? Will it potentiate its action? Will it be a synergist? This is what pharmacodynamic deals with. So pharmacodynamic drug-drug interaction actually deals with, let's look at this example. It deals with the following. Synergists. Are you a drug that is synergistic? Will you cause my action to be if you give two drugs, will it cause the action of one to work better? Addictive. If you give two drugs, will it make one to become more addictive? Normally, if I should take this drug, I can do it. But when I take the two together, I can't do without one. I can't do without it. I become addicted to it. Is it antagonistic? If I should take one drug, will it prevent the action of another? Will it bind to the receptor that other drug is supposed to bind to? Will it nullify the effects completely? This is what this one does. So let's just look at some example. For example, if you give somebody non-selective beta blockers, what do? They block beta receptors. Non-selective, they can block both beta 1, beta 2 receptors. So if you give somebody non-selective beta blockers, example propranolol, and you give somebody bronchodilators, example salbutamol. Salbutamol is beta 2 agonist. Do you get that now? Beta 2 agonist. It wants to excite beta 2. Propranolol is beta 2. It's an antagonist to both beta 1 and beta. It will go to beta 2 and block beta 2. Salbutamol will come and want to excite it. What do you want to excite when it is blocked? That's an antagonistic effect. If somebody that have asthma, you give the person selective beta 2 agonist like salbutamol to make the airway to become dilated. Now you not give the person propranolol also. Propranolol will go to those receptors and block the side that salbutamol is supposed to act on. So salbutamol will not have it if you're done. So this antagonistic effect, that's an example of antagonistic effect of pharmacodynamic drug-drug interaction. Do you get now? Now another example. This one is, we want to talk about synergist effect. It potentiates the effect of another. Loop diuretics, for example, furosemide, can actually potentiate the toxicity of cardiac glycoside, digoxin. How so? Digoxin causes hypokalemia. Now, you are giving somebody loop diuretics, which also causes hypokalemia. What are you doing to the effect of digoxin, that toxic effect, that hypokalemic effect? You are increasing it. One thing causes hypokalemia. You are not giving two things that will cause hypokalemia. That's synergistic. You are like, they are working together. They can be working together doing good things or working together doing bad things. In as much as they are working together, it's a synergistic effect. If they are working in opposite directions, it's an antagonistic effect. So beta blockers like propranolol and salbutamol, which is a beta agonist, they are antagonistic, working opposites. Cardiac glycoside and furosemide are synergistic, going to the same direction. Do you get this at all? So that's what we are trying to explain. Then let's talk about addictive. For addictive, combination of antihypertensive agent called alpha-metidopa and atenolol makes it addictive. Normally, when you take alpha-metidopa, it's not addictive. But when you take it now with atenolol, it becomes addictive. That's addictive effect. Example of addictive effect. All right. So this is physiological mechanism of drug-drug interaction. Please, you can go through this The video is becoming too long, and this is conclusion. Conclusion, we just know that drug-drug interaction can cause what now? It can actually cause either positive effects. It can potentiate the effect of a drug, make it to work better. It can cause adverse effects and make a drugs not to work at all. Sometimes can make the two drugs not to work at all. They will just destroy their both effects. So it can cause mortality. It can cause hospitalization. It can cause severe drug reactions. Thank you very much for watching this video.